how do you tell the story of your work? So that way people can understand it and actually have buy-in to what you're doing. How do you tell the story of the idea that you've come up with and how it might work or impact folks' lives? And of course, physicians are trained to be storytellers, just in a different way. But that's part of becoming a more effective, efficient physician or surgeon, is that you can tell the right story of the patient to the person. You might be tailoring it to that audience for whatever the next step is in that patient's care journey. And that's going to be part of what it means to be a leader as a physician in the future.
All right, we have another exciting episode of The Alchemy of Politics. I'm your host, Dr. Rusha Modi, and the premise of this show is, as always, to talk to the smartest, most creative people solving society's most wicked problems. And today I'm extra honored and excited to have Dr. David Janka here as a guest today, professor, doctor as designer, freelancer, and overall just innovative, creative badass, I think, from the Stanford Design School, who is here really to show us how to be more innovative and creative in a number of different ways, not only in our careers, but also in healthcare. He has a long and storied history working in some of the most respected institutions that we have, UCSF, the Hasso-Plattner Institute of Design at Stanford, as well as the School of Medicine there. So thank you so much for joining us on the show today.
Great to be here, Rusha. Thanks for having me.
So as we were chatting before, one of the things that just was so impressive about you was not only, this sort of straddling between, deep understanding of hardcore science, but also this sort of agility in thinking involving very creative and artistic disciplines. And then also how you sort of charted a very novel sort of path for yourself in your own career. And I work with a number of physicians as well as trainees at various levels, especially when I was in academics for a number of years on faculty. And people are always trying to find their own way in healthcare because it can be so intimidating. And there isn't a lot of guidance, especially when you're coming up to kind of make sense. I know you do a lot of that, in your current position. Maybe walk us back, if you can, to earlier in your life when you were starting on this perhaps different journey. What prompted you to even say, you know what, maybe full-time clinical or academic work isn't really for me, and I have this other itch to scratch. What prompted that? Or was that something that you knew going in? And maybe even more importantly is, where did you find the courage to be able to follow that sort of unique path?
Yeah. Okay. Where to begin? Well, in some ways, my journey or my career in healthcare started out as very traditional and predictable. So, was a big science nerd all through high school and undergrad. Really loved biology and chemistry and biochemistry, like all of that, just understanding how the world worked and the human body worked, kind of learning all of those mysteries. And I also worked in labs over the summer, so doing basic science research, and then some things that moved into a little bit more of like the clinical trial space, and was on this pathway to be an infectious diseases doc.
Yeah.
I then, after my second year of medical school, spent a year in Kampala, Uganda, as part of a clinical research fellowship through UCSF. Mm-hmm. And, for me, I was kind of seeing like on the spectrum of healthcare from like, thinking on the molecular level to the cellular to the human body, and then starting to think more about like, society and kind of like larger questions. I kind of felt like I was sliding up that spectrum a little bit. And so that year in Uganda, working on this clinical trial, we were wrestling with interesting questions related to the pathophysiology of what we were studying, but also just the dynamics of people's lives and what it means to have access to healthcare and access to resources, and how to, adapt clinical trial protocols to environments with different constraints. And so getting into this problem solving space that, wasn't about quote unquote science, but was asking really important questions about function and service design, even though we weren't necessarily calling it service design. So I think that kind of was a culminating experience. And, in my initial journey around infectious diseases and healthcare. And when I came back from that year, did my first year of rotations. And so again, was starting to kind of, increase my understanding and sophistication of the healthcare landscape, but was continuing to ask some like bigger questions and really starting to think about, what are the roles of physicians in healthcare today and in the future, with all of the complex problems we might be trying to solve, or at least make some headway in. What are actually all of the different tools and approaches that are needed? And I was also, having a little bit of a second guessing of, wait a second, is this exactly what I want to do? Do I still want to do internal medicine? Like, there were some great things about pediatrics, and like, I didn't hate my surgery rotation. So I was in this space of really like looking and trying things out, and decided to take a quarter away from like the regular medical school track, which I was very lucky to be at Stanford. They had a little bit more flexibility to explore like that. And in that quarter, I just took other classes on campus, and two of those classes were in the design realm. So one was more what we would think of as traditional design. It was an intro to visual design, and then I took a class at the D.school, which had only been at Stanford for 3 years at this point, and it was an introduction to design thinking. And then I was really seeing this other more kind of strategic design approach to problem framing and problem solving, and that's where things really kind of changed for my career trajectory.
That is so fascinating. I mean, to kind of ask for questions about that. I mean, did you pick design classes at random? Clearly not. It seems like those particular classes spoke to you. I know so many people that struggle even at that point in healthcare, because it's just such a overwhelming process to just get to that point where the pre-med classes and the research, and you got to learn this. And, you were starting basically your clinical rotations in the second half of training, where it's like, you got to learn a lot of clinical science. You got to get, clinical experience letters. You got to impress your attendings. They're trying to pimp you. They're trying to there's a lot going on. So you actually took time off, which is very unusual. That's a huge level of sort of, I think, confidence in your own path and your own decision making. But what was it about design? What else were you thinking about taking? Just curious.
Yeah, I mean, I took like an intro to bioethics class that was at the law school. There was another class at the business school, kind of in the venture space, like biopharma. The first time I was like, oh, there's this term called market cap. There were just like very rudimentary things that I was starting to get my hands around. I took a medical Spanish class. So like a few different things there. And I was just looking to see what might be interesting and stimulating, that could, allow my curiosity to go somewhere, and somewhere different than I had been really putting it in medical school up until that point. And I had found the D.school, I think like their website or something, over the summer before I took this quarter off. And they had like tours you could go on. So I went and met some of the people there, and then just like really got stimulated by the ethos and even, the space and kind of that way of working. And so I knew I wanted to get a taste of that, and at least experience it a little bit. And that first class was very introductory, so not healthcare themed. But then after that, I took several more classes at the D.school that intersected with healthcare, either explicitly in the framing of the course or with the projects that we were involved in. And that's where things really took off for me, because even though I was still, I don't know how you exactly place yourself in a medical education journey. It almost always feels like you're at the bottom, like you get to the next step and it's like, nope, you're at the bottom again. But in my kind of role in those classes, I was like bringing medical expertise and an understanding space. and collaborating with, an engineering student and a poli-sci student or a business student and a law student. And so I was able to kind of, leverage that healthcare interest and knowledge and experience in new ways that felt really exciting to me. And, a lot of medical education, it's kind of narrowing, like you're choosing a specialty, maybe then you're choosing a fellowship underneath that, and maybe you're choosing like the exact question you're going to be researching. And I was finding that design was kind of liberating that a little bit. Not that one is necessarily bad or better, but I was like exploring lots of different questions. And I liked that. I liked, moving from one topic to the next. It just felt very freeing. Yeah.
I love that. I mean, that speaks to so many physicians. I mean, I can't tell you privately how, even sometimes publicly, how many physicians I know from all kinds of backgrounds that say like, hey, I enjoy taking care of patients, but the sheer monotony of like the same 4 bread and butter conditions that I see day in and day out ends up just being really quite stressful, that there isn't that ability to stretch your legs creatively, so to speak. And so I love that you were able to do that. And I guess the thing that strikes me about your description of this is how you are fascinated at looking at concepts and problems from multiple different angles. I mean, classes like I was a bioethics major in college. As we discussed, I had an extensive history in visual arts before I went to medicine. And so, yeah, they ask not only different kinds of questions, as you know, but they approach those questions in different ways. I love that you were taking these different disciplines that had their own ways of looking at the world, because yes, medicine can be very powerful, but it can be very, very narrow. Was that something that was always part of kind of your spirit, if you will, growing up? Because looking back, it seemed like you had such a traditional path. You ended up being like, I think, a Doris Duke research fellow. You had been going to, abroad to study infectious disease. You learned all the basic hardcore biology. Was there always this part of you that's like, I like to kind of mentally dance and sort of think about a problem from a very different angle and like, what would happen if we, did this? Or was this something that just emerged later as you were kind of developing into your medical training?
Yeah, I think the latter. I think really it wasn't until I started playing a little bit and taking a little bit of a break that I was able to foster that side of me. I mean, I think there were pieces of it that were always there. But kind of like I mentioned earlier, like I was just very motivated in high school and undergrad and focused. And so just all of my energy went into that work. And I was still taking electives and honors seminars and like exploring some other little pathways. But yeah, that just like really took the bulk of my energy, and I think in a good way. But it was really at this time when I was, in some ways it's like the didactic nature of like you're given projects and you're given questions, and then it's like you're giving yourself permission to invest in that a little bit. And it was in like a little bit of a different posture. So, maybe not mysteriously here in a visual design class, you're like buying art supplies and like making things.
Yeah.
And that's just kind of like a nice treat. Like I'm in the middle of medical school, but now I have this list of like art supplies, and I'm going to take this list to a store and like buy things and then use them. Like not rocket science, but it was just like the forcing function of that. And then in the introduction to design thinking class, we were starting to learn some of these other methods of inquiry and other tools to understand problems and frame problems, and different interviewing techniques, which, like in medical training, you're learning how to interview from day one. Even in your first couple of years that you're emphasizing basic science, we were still taking, classes in that realm. And so I kind of came into those sessions being like, I think I know how to interview people. I interview people about like really intense personal things. But this was just a totally different way of engaging and active listening. Even the way that we were synthesizing information and generating ideas and prototyping, it just was, a very kind of liberating experience. And I don't know, it was kind of nice being like almost forced to do it, because I had signed up for these classes, and then I was able to release a little bit, like kind of just like trust the process, like trust the course. And I think a little bit of that is needed to gain some new skills. You kind of have to relax a little bit and say like, okay, I'll analyze and critique later. I'm just going to see what this is like.
That's funny that you mentioned that, because I would say that as a general rule, obviously there are a lot of exceptions. I would not make the characterization that med students know how to play. I feel like most of them are so pressured to find their career and figure out the rotations and get the exact sub internship that they need, and then do the away rotation just to line up everything so they can match, so that they can do this. And through no disrespect of their own, I mean, obviously that's a worthy goal, but I can only speak for the students I've worked with, how I was back then. Just the sheer overwhelming sense of having to get to the next thing. I feel, and correct me if I'm wrong, because you're the expert, is kind of contrary to the nature of play and recreational thinking, which is kind of being more in the moment, allowing the pressure to come off, giving yourself the permission to ask what if, as you said. So what was it that even allowed you to do this? I mean, I know plenty of people that, hell, myself even, I felt during med school like, hey, I would love to get back into visual arts. But, I kind of did stuff on my own a little bit, but that was just it. It was never a formal sort of side venture that ended up being much more in your case. So did it seem like a no-brainer? Like, yeah, of course I'm going to take a semester off and try these different things. Or was it sort of like, an act of courage, an act of defiance? Was it just so a non-event that you're like, this is just what people do? Of course I would do this. Like, what was it that allowed you to even take that step, as opposed to kind of saying, I'll get to this someplace down the line?
Yeah, I think it's a mix of the things you listed. So some of it was, structural, like being at an institution that allowed for some of this flexibility.
Yeah.
Just knowing that, like, it could happen, and it wasn't like I was going to be appealing some committee. So I know that's a situation that's not true at every medical school, but at least at the time at Stanford, that was something that was possible. And even though there was not a model of people doing exactly what I was doing, there were other examples of folks you either knew directly or, kind of like legends from previous years who had tried something or experimented, or like, oh, they got, their master's of public health degree in London, they did a summer working in venture capital. So you had like some examples of those explorations, which I think gave me permission to try my own. And then I think a little bit it was a leap of faith, and just thinking like, okay, even though there's this very regimented, structured medical education, and there's cycles and seasons, and if you get off at one point, it's like you got to wait a year to get back on. And I knew about those things. I just tried not to like obsess over it, because there's going to be some uncertainty there. And I kind of had a little faith, like things will work out, and I can lean on my previous, experiences and things that I've done. I might just be framing that story a little bit differently, but there was also an element of just like, well, like, let's see what happens. So maybe that's the leap of faith part of it. And then once I kind of started and was working in that way, I'll admit, then I just wasn't even really thinking so much about the next step. I was able to kind of just be in the moment once the decision had been made. And I think there was also something about it being a little different, a little mysterious. I remember talking to an advisor at one point, telling them, oh, I'm taking classes at the D.school. And they said, oh, that's so interesting. I didn't know we had a divinity school. Stanford does not have a divinity school. But there was also something about like, okay, like I'm kind of in like a little separate playground.
Yeah.
So yeah, but it is kind of hard to think back to that time, just because I've changed so much since then.
No, I know. And the reason I ask, I mean, I think probably 90% of these questions, I'm probably speaking to my younger self, but it's also like, I know so many people that have so many interests that are vibrant and captivating that, medicine requires to a certain degree that you put to the side for this sort of noble but very rigorous pursuit. And I feel that, and I think this is a very healthy trend, younger physicians and current trainees are questioning that a little bit, saying, can we integrate these disciplines into medical training and expand what it means to get an MD or a DO, as opposed to this sort of very narrow sense of what most medical education is. And I have a lot of friends that are deans of med schools and medical education programs, or in like residency programs with, ACGME. And I mean, this is an active area of debate, is like, how liberal, lowercase l, not politically, should these curricular sort of offerings be? I want to get to the re-entry point in your career when this semester is done. That must have been a little bit different to kind of step back into rotations and the swing of things. That must have been a little jarring, I would imagine. Do you recall what the mindset was? Was it already in your head like, wow, I'm going to have to re-up my entire life plan at this point? I got to figure something else out. I'm going to have to talk to somebody. Or was it just simply like, hey, I had a great intellectual vacation, I feel rejuvenated, and who knows what happens?
Yeah, it was more that I had mentally going into it was like, this is going to be a quarter to kind of explore and play. And then I'm, back to the rotation. So I think I had just like moved some around. Maybe I forget what I started. I might have done like an ophthalmology elective or something like that.
Yeah.
And so that just felt like what the plan was all along. So kind of went back into it, doing rotations and going through the roller coaster, which was different from every rotation. Of sometimes it's like, you love it and then you hate it, then you love it, then you hate it. It's like, where do you land? And they were all great. And I think I was even approaching those rotations with a slightly different mindset. I didn't have a clear way to necessarily apply it. But, just in the way that we were asking different questions and considering possibilities and even building and making ideas, even if they were stabs in the dark. I think I was looking at those rotations with slightly different eyes, but still not ready to really leverage it. And so then it was kind of back to normal. It was more like thinking back, oh yeah, that was like a fun quarter. There was, some other classes that I knew were happening at the D.school. And maybe there were moments of like, oh, that was such a cool class. Like, what would it have been like to, take that class? And then I eventually did the next year.
Yeah.
And so, essentially reached a point after, I guess, what was it? Another, 9 months of rotations, probably somewhere in that summer when it's like, it's time to start, personal statements and things again, where that, little design seedling that had been planted was like growing. And I just kind of felt like there's something here that I need to explore. I'm feeling this like energy and attraction to this space. There's more classes that I can take. I'm in this unique position right now of like still being a student here where I can do that. And so, maybe like the first leap of faith cracked open the door a little bit, because then there was another leap of faith of like, all right, so I'm going to, move my sub-I and finish my, other required rotation in the fall quarter. And then I'm just going to devote the last 2 quarters, quote unquote, of medical school to classes at the D.school. And I didn't know what I was going to do after that, but I was just kind of like, yeah, I mean, I have skills and I have knowledge and I'm resourceful and like, I'll figure it out. And then just spent the next 2 quarters all in. I think I took like 6 more classes. And so that was a crazy 6 months, but yeah, that definitely kind of solidified the shift for me.
And then at the end of that, the thought was, okay, I'm all in, and gonna have
at the end of that, I was like, maybe, residency is still a possibility. I was thinking about, other ways to kind of just like apply my skill set and work in different environments. So I, even looked into like the traditional management consulting route, and a couple of the I don't know, what is it, big three, big five, however, whatever designations people have. They have like specific programs for folks with PhDs and MDs. So I did, it's like some, I don't even know what you called them at the time, but like you'd go out, fly out for a weekend and like do some case studies and meet some people. So like I thought about that. There was also like the design consultancy world. So, in the Bay Area, right near campus, you've got IDEO. Some of my teachers in d.school classes worked at IDEO. And so I was even, exploring that, what might that look like? And I think at that time, I had heard of this. It had since developed a little bit more, but there was even precedent of medical professionals doing like internships or like a year at IDEO. So like folks in their surgical residency programs, when they would get like a year or two, depending on the program for research years, sometimes they would come and work at IDEO for a year.
Wow.
I knew these things were happening there. And then from two of the classes I had taken, we had continued the projects. They were like little startup projects. So part of me was like, maybe I'll do the startup thing. That was very much like in the air. This is like 2011 in the Bay Area. And then this other thing popped up, which was a fellowship at the d.school. Mm-hmm. And there had been precedents of that, of fellows before me, but the program is always kind of evolving. And there were only 2 spots. So that was one of those things where I'm like, I hope it works out, but there's no guarantees. And so I applied for that, and I got that fellowship position. So then all the other things that I had been thinking about, it was kind of like hit the snooze button again. Yeah. And then I was, all in at the d.school, teaching and exploring. And really, I think at the time, part of some folks who were really cracking open this space of healthcare and design and what could that mean. And so that was also a really exciting time to be kind of mapping the landscape and seeing which institutions were experimenting and which, quote unquote, renegade MDs were doing things a little bit differently and like remixing skill sets. And that's where I really started to feel like, okay, there's something here. It's going to be a little bit of like inventing a career or like figuring it out as I go. But it was exciting enough that I was like, I could kind of see like the decisions I had made, the leaps of faith I had taken, were kind of coming together here. And so that felt like worthy to invest in, and also just like totally energizing and engrossing. And so it felt right.
Wow. Then the rest is kind of history, it seems.
Yeah.
Wonderful. I love that. And I wish this was offered more to people at any level of training, that there are these opportunities to craft something that's a little bit more unique, that fits you better. And I so feel that the field needs this level of sort of novelty of sort of pedagogical approach. For some reason that just does not exist in healthcare. I mean, medical training is basically structured no different than like 100 years ago, as you know. I mean, the content is obviously updated, but I think these other disciplines are so vital. So maybe walk our audience just into like, a couple minutes, if you don't mind, like on a primer, sort of like what are the basic principles of sort of D-health or design thinking writ large, maybe?
Yeah. So, design thinking is an interesting term that can mean different things to different people. And I think especially recently, it's kind of being pigeonholed into this very narrow space. So I'll maybe just start with how I conceive it much more widely. And usually when I kind of introduce this concept to folks, like in the context of a workshop or teaching, I use the 3 A's. Okay. So you can conceive of design thinking as approaches. That's the first A. And this is commonly what people, how people are introduced to it. So an approach being like a method or a strategy or a process. And so often people think about, quote unquote, the design thinking process, which is like pretend, because there is no the design thinking process. Often what I think people conceive of or reference is what we at the d.school teach as like kind of introductory training wheels, like for like beginning students, like here's like a kind of an oversimplified way just start to think about the fact that there's these different modes that you're in as a designer, and that there's different tools associated with that. And you can almost start to think about cycles. But of course, it's way more complicated than that, way more nuanced than just like 5 steps. But regardless, designers of all sorts have approaches and processes and ways that they navigate their work. And they may be very structured, they may be very unstructured, they may vacillate between moments of structure and total lack of structure. But there's, a way to conceive of design thinking as these approaches. And that can be something to learn, like the steps you might take or the different modes you might be in. The next A is attitude. So I think you can conceive of design thinking through the lens of attitudes. And this is like mindsets, philosophies, or, ways of working that, transcend a process, or even transcend working on a project. So what are the intentions you're setting for yourself in this work? So, a few examples of that. One that's easy, radical collaboration. So part of being a designer is getting outside of yourself, collaborating with people who have very different perspectives and expertises. And especially when you are tackling complex problems, you really need to think about it through many different lenses, lived experience, traditional expertise. I think it also is helpful to have some like wild cards or some like very alternate perspectives. So that's kind of the approach lens. And then the third A is abilities. So you can conceive of design thinking through the lens of abilities. So what are the skills or the muscles that designers use that we can incorporate into, a process with certain mindsets? And so some of these are, more straightforward. Some of them are a little bit more abstract. And I'll even just, leveraging the abstract framing, there's an ability that designers have to move between concrete and abstract. What's the actual thing that we are doing with the numbers and the math and the reality of the materials at hand? And then, well, what could be possible? How could we completely reimagine this? And so there are skills involved in having a concrete approach and skills involved in having an abstract approach, and like tools and frameworks that you can learn to improve that. But then there's also something about being able to switch between them, or at least identify for this moment of the project or for this moment in our team, how are we working? Are we working in like a concrete kind of focusing way, or are we abstract and flaring and considering possibilities? Another skill is navigating ambiguity. And it's something that can be really hard because there's like an emotional component to it. And for some people, like anxiety and stress. But, life and all forms of work have ambiguity. And how do you actually manage that? And I think this is something that, really resonated with me as being different or in tension with healthcare, because so much of what you're being trained in as a physician is to minimize the ambiguity as soon as possible. Like,
yes,
what's the differential? Narrow the differential, make the decision, move forward. And of course, that is incredibly useful. And in so many situations, like that's what we want. It's like, I need the person who's going to narrow that differential.
Yeah.
But what can happen, though, is then it can be difficult sometimes for some people to switch out of that mindset. And whether that is what we were talking about earlier, playing, or just giving yourself, I don't know, a day, a week where you don't know the answer, and being okay with that, and not feeling like that's, impugning your character, it's fine to not know for a month because you're exploring and learning. So anyway, that's another kind of skill or ability. So yeah, that was a lot there. Do you want to follow up on any of those elements, or I can keep going?
Yeah, no, that was a brilliant overview. I mean, I think the one thing that kind of, and I don't know if this is even accurate, definitely, let me know, that came to mind was the parallels between what you described and actually improv comedy. I took a number of improv comedy classes, when I used to do some acting work, early in my, as a parallel interest of mine, just like yours, when I was actually in residency. And this was very similar to some of the principles of like yes and, where someone gives you sort of a setup for a joke or something, and the thought mentality is yes and, okay, I'm going to take this and I'm going to add to it, just like radical collaboration. Or number two is like agility in thinking. And then three, probably the biggest one that for me was insightful, was it's okay to play, to explore. That it's in fact in your mistakes, when something goes wrong with the setup of the improv scene, that's where the comedy gold is, which is so orthogonal to the medical mindset, where of course mistakes are potentially catastrophic. And there is an agility in being able to allow yourself to relax, and that was something that was freeing for me, because I came in, and I still struggle with this whenever I do take, any improv work here and there. Then I struggle with the sense of like, I have to think of something. What's going to be funny? Where's this setup going? Let me figure out, what if they say this? But then you're already out of the moment. And being okay with like, they're going to give me something to work with. I won't actually know at that moment what is going to be the next line or action or setup, but trust that something is going to come out if I'm open to working with, an alien from Mars that comes down and is cooking cupcakes. Okay, go. And I feel like there is some philosophical similarities with kind of what you described. I mean, do you see that, or am I kind of making a connection?
Yeah. And I mean, I would say, I mean, even explicitly so, in the DNA of the D.school, and then in the DNA of like the foundational courses, and now kind of, just ways of working and teaching at the D.school. I mean, we had folks who do improv as part of the classes.
Oh, wow.
Even at the beginning of the class, you're doing, we often refer to them as like Stoke activities, but they're leveraging sometimes literally like the same type of like improv warm-up activities you might do at, like, I don't know if you call it rehearsal, but like when folks get together to refine their improv skills.
Yeah.
And part of that is, shifting energy. You think about it like you have this class at Stanford where people from all different graduate programs and professional schools are coming together in the same room. And of course, they're not all going to be aligned. Like their minds are doing different things. So a way to kind of shift the energy of like, this is how we're working in this class today in general. And then depending upon what we were learning, there might be like a Stoke or an improv activity that would specifically be connected to that. So for instance, if the focus of the class was on ideation, generating ideas, building off of each other's ideas, we might do an improv activity before that was doing that exact same thing, like really listening to someone and responding and being positive and building things. Other days you might be prototyping. And so this is about like making and remaking and using materials and furniture and your bodies. And so on those days, we might do an improv activity where like you're really physically like interacting with the space, or, contorting your body or playing different roles. And so just like loosening yourself up. And so, yeah, that's very much woven into the DNA of the way that we work. And even, when I teach students, or when I do workshops for clients, like that is an element and a consideration as well. It's also part of, I think, creating engaging learning experiences. Like these are not classes where people are sitting at desks that are nailed into the ground with a laptop in front of them. Like you need to be moving around and doing things. And part of that's like paying attention and keeping the class engaged, really thinking about experiential learning and all those different levers. And this was even something for me that was very attractive about the D.school, as I was like, oh, our teachers are like incorporating music and videos, and there's like a GIF in that slide deck.
Yeah.
And that slide is actually just like a full bleed image, and it doesn't have like 2 paragraphs of text that I'm going to have to read later. Like mind blowing. But there were just like in some ways low-hanging fruit there around experience design and visual design that I was even like, oh, this could be beneficial in healthcare, and like what would it look like for some research presentations to borrow from some of this, or even educational content. So I think all of that gets woven together. I think the other element that is part of this is storytelling. How do you tell the story of your work, so that way people can understand it and actually have buy into what you're doing? How do you tell the story of the idea that you've come up with and how it might work or impact folks' lives? And of course, physicians are trained to be storytellers, just in a different way.
Yes.
But that's part of, becoming a more effective, efficient physician or surgeon, is that you can tell the right story of the patient to the person. You might be tailoring it to that audience for whatever, the next step is in that patient's care journey. But again, like it's one form of storytelling. And I think like there's an opportunity for like other storytelling techniques in a physician's toolkit. Because there's other audiences that I think physicians are increasingly going to be responsible for engaging with. And that's going to be part of what it means to be a leader as a physician in the future.
I so love that concept. That is brilliant. I mean, I would encourage everyone listening to just like rewind in the last 2 minutes and listen to that again. I feel that the problems in healthcare and in health, or the lack thereof in this country, really are only going to be addressed and really handled if we have, as you say, different storytelling approaches. I think that I can think of countless examples where a pure biomedical approach alone is insufficient to the task at hand. I mean, one classic example that I think comes to mind is, Angus Deaton at Princeton has coined this term deaths of despair, where he's an economist actually, but has cited public health data on the rise of suicide, parasuicidal behavior, hepatitis C, alcohol, drug use, obviously the opiate epidemic. And these are, from a medical standpoint, really severe and important health concerns. But what he's really tied into is this story, like this is about despair. This is about largely young men with poor economic prospects who've been left behind in our modern society, in a country that has, decentralized and decaying public institutions that don't have support, and they're acting out in all kinds of terrible and unproductive ways. And that is actually manifesting in terms of very particular, unique biomedical conditions. That would be a hard story to tell if you're purely on the clinician end and you're just seeing, all these patients. You need a different lens to be able to kind of step around and say, what's coming from the back end? What's the larger narrative? And I feel like what you just said, like to be a leader in healthcare, a doctor as a leader, you need to have multiple storytelling tools at your disposal. That is what I love about your career. That is what I love about what you just said. How do we get that message across? Because I know, and there was actually an editorial in a number of both public journals like outlets like the Wall Street Journal a couple of years ago, as well as in academic medical journals, about the debate about how much medical education should be broadened to include somewhat non-traditional disciplines. And just as an insight, I actually was a member at USC for a number of years in health systems innovation. That was my area of research. And we were working with the school there to include that in the curriculum because, med students are entering into a profoundly broken and hurting industry where, so many ways of how we actually deliver the care that we are trying to give is itself, insufficient, failing, often at odds with what we're tending to achieve. But there's no science that is taught about like how we do that. So how do we communicate this message of like, we need other storytelling tools, we need other pedagogical tools, we need other hats, if you will, that someone can put on? And I feel like in improv and visual arts history, it's what you've described about D-health. That's almost a given. Like, yeah, of course, one approach is not going to be it. Like, I need to figure out multiple ways of how else could we address this problem? As you said, like, what are other ways, shift between abstract and concrete? Like, that almost seems part of the DNA of a designer, whereas for some reason that isn't of a doctor. How might we kind of bridge that gap in your workshops? Has this tension come up? How do you adjudicate that?
Yeah, I mean, it's a great question. I think that intersects with, a few things you've previously mentioned around like the time and space to, have these other kind of explorations or learning opportunities within the rigid structure of medical education. And perhaps even just like, I don't know, early medical career development. I'm not sure when it gets flexible. So I think there's definitely some constraints there. Part of this for me is also recognizing that we're not at zero, we being like healthcare. There is precedent, there are examples of folks who are in different arenas, whether it's more of the like business space or healthcare administration space or politics and advocating for systemic change at that level. I think there's interesting intersections here around like physicians and public health. And so I think in those different arenas, there are examples of folks who are operating at a really high level. And so there's something there to me about, I don't know, celebrating that, maybe capturing it in a way, sharing it. It's, again, one of these constraints. There's only so much you can expose people to during medical education, and it's always a choice of what you're doing. But I don't know how much of these like alternate pathways really become part of how physicians are trained. They kind of have to seek it out on their own.
Yeah.
And so I think that part of it is just seeing those examples and seeing the way that that happens. And some of it is, practice and exposure, and it doesn't have to involve, getting another degree and like pressing pause on your life and going all in on that. Like, I think there's other smaller ways to get some of that exposure. I'm even thinking of, one of my D.school classes, when we were getting kind of to this stage around like, okay, you're coming up with this idea, how might you be pitching it to people? One day in class, we did these like elevator pitch drills. And so, there were like these sliding whiteboards. Those are like the elevator doors. And one of the instructors would be waiting behind that. And I think that had like a name tag on or something like that. But the door would open and it would be like, all right, you just run into Bill Gates and you've got 60 seconds before you get to your destination, like pitch. And, you sometimes didn't do it great. Sometimes you did better than you thought, but it was like, just like practice drills of pitching and storytelling to different audiences with different amounts of time. Some of it's just like doing that and recognizing what you do well and what you don't do well, and refining that. And so I think there's opportunities for practice as well. Whether that's like a workshop or a course or something like that. But yeah, I think that there's work to be done there in terms of how do you actually get people the freedom to do a little bit of that exploration.
Yeah, I mean, I so wish that. I mean, that's why I was so excited to have you on the show, that physicians are exposed to you and this approach that you embody, because I think it's so needed in the field. Let's transition to kind of one other concept that immediately came to mind when you just kind of outlined the 3As and the different approaches, and this sense of productivity and efficiency. I mean, if there's any drumbeat that the modern working physician or even in academics hears, it's you got to be even more productive. You got to publish even more papers, get more grants. Your dossier has to be even longer. You have to see even more patients. You got to churn out more RVUs. You got to code more, bill faster, see more, stay late. It's more, more, more. Less is more, more is more. And that is really the only metric that ever counts. I had a number of physicians recently comment to me, they only hear from administration with concerns about them not seeing enough patients, despite the fact that physicians are just busting at the seams with work. that seems profoundly different than the messages that are echoed, in your world. Which isn't to say that that's not anti-productive, but that productivity isn't the sort of the idol that you worship in design thinking. It's maybe innovation, creativity, this sense of, mistakes are okay in the process of a different story. What would you say is the kind of overarching sentiment in the world of design that is different than what physicians are constantly beaten with?
Yeah. I mean, that's certainly a tension in design, even thinking about, going between concrete and abstract, or going between like exploring and delivering. And designers have clients, and there are constraints, and there's time allotments, and there's budget. And so constraints are certainly part of the way that designers work and have to kind of navigate their approach to their work. And there's a whole, I think, other interesting tangent around the fact that, constraints are good for creativity. And even sometimes in our work, we bring in constraints. Sometimes like a totally blank canvas is paralyzing. And even in terms of like generating ideas, just sitting down and saying like, let's generate some ideas can be like, but if you have like a really good frame with some constraints, that can actually fuel that. Anyway, that's another tangent, but yeah, I mean, I think one mindset here, I think comes around like how you're bucketing time. So like short-term productivity versus long-term productivity. And maybe this is a little bit of hyperbole, but in the case that you're talking about, like, yeah, you might be able to like increase the productivity of your physicians in the short term and measure that by like daily, weekly, or annual outputs. But what does that look like over 5 or 10 years? If people burn out and leave, and then you have to reinvest money in training, and like all of these other things happen, was it really that efficient?
Yes.
To, exploit the physician in the short term? What happened in the long term? And so I think there's some of that I connect to, learning how to design and collaborating with designers, where you almost have to say like, okay, well, this half day or this day might not feel efficient or feel productive, or we might not be able to like articulate the ROI on that exploration, but it's in service of getting us to a place 3 weeks from now that we wouldn't have otherwise gotten to. So, some people, even really kind of defend the fact that like my work is efficient in the scale of,
yes,
2 months, even if when you look at like a day-to-day basis, you don't think that was the most efficient use of time. So I think it's, what are you playing with? What's the goal? Are you trying to really come up with new ways of looking at things, or innovative solutions? If you can't get to an innovative solution with super regimented productivity, like you're maximally inefficient because you didn't do anything.
Exactly.
But it's a balance here, and it's not either or. It's not like waving a wand. This is part of what it means to develop, I think, as a designer, primarily, or as a physician who designs. Like, how do you balance those constraints? How do you think about short-term wins and long-term wins? And yeah, I mean, I do think that the picture you painted, the dire picture, is a real thing that it seems like healthcare has been wrestling with for a while. It seems to have only gotten worse in the last decade. But I think there's going to need to be a reckoning around the structures of not only medical education, but the healthcare system, the incentive structures there, and really like some long-term thinking about, what does it mean when you've stressed out and burnt out your workforce? I think we saw there's some parallels, or like an analogous situation I think about even with COVID. And I'm trying to remember where I was first hearing about this, but I think it was related to the fact that over the years leading up to COVID, many healthcare systems, in the pursuit of efficiency, were reducing redundancies, which on the surface sounds like, well, yeah, we should do that. Leaning out supply chains, minimizing stockpiles, like all of these things to be leaner and more efficient. And then what COVID did to some of these healthcare systems that had done that is made them realize, like, wait a second, like, by removing these redundancies, we are now at more risk. Yes. By leaning out our stockpiles, we were not able to meet the needs of the moment. And so what was the right answer? Like, maximizing the profits and efficiency in this like 5-year span of time, or the fact that it led to like some massive failures in certain contexts when this event happened. So I haven't, readdressed that specific use case when I was first reading about it to see if there's been more, synthesis and reflection on that. But it seemed to me to be like a really good example of like, you can't just think about the short term. There's like this long-term efficiency or long-term success that's part of the equation.
I mean, I had a lot of friends actually who worked in sort of, import export, and they were working with suppliers in China when the pandemic hit to get us PPE. And, I understand the need for efficiency. I just didn't understand why it was reduced to the point where there was a single point of failure. That never made any sense to me. But the economics of it was China has and continues to be the source of cheaper products, cheaper labor costs. The economies of scale just made it that everything should be manufactured there. And then, look what happened, and sort of history was made for better or for worse. I mean, so I guess that almost, because that was actually going to be the first question that I was going to ask, like, how would we apply design thinking to worker burnout in healthcare, which is at record numbers? But it almost seems like the real innovation is going to be in the shift in mindset and thinking, like, how do we incentivize people in healthcare, especially administrators and leaders, to think differently about, I guess, time? That's one lens you've pointed out, like short-term versus long-term. And then 2, what values the system honors? Is it purely efficiency? How do we conceptualize that in a broader framework as opposed to just a narrow definition of that versus other metrics that might make sense? Quality of care, or, physician worker wellness. So what might be an initial sort of brainstorm of like, okay, we got this problem. It's a systemic issue in healthcare. We got 3/4, according to most surveys, of physicians that are actively burnt out, thinking of retiring early, and in most scenarios would not recommend a colleague going into this field, nor would they have done the same thing themselves if time went back. 500,000 nurses left nursing during the pandemic. That is an insane number of people. This has actually become a real crisis, especially in rural areas where they were already understaffed to begin with. So like, what might be just the couple first points? And we don't even have to sketch out a solution. Obviously, this is a big problem. This would be a whole series of workshops. But how would a designer even think about starting to address something like this? Like, where do we begin?
Well, I think the first thing I'll say connects to even the way you were framing things a few minutes back around like systems design. So recognizing that there's, different levels or layers of design, and, where should we be operating, and what, therefore what questions should we be asking, and which stakeholders should be involved in that. And so, you might think about like some layers being like, visual design, or even like the product design, like the things. And then you're thinking about experiences and services and programs. And then layering up, you're thinking about like strategy, like strategic design, and then, systems design. So I think there's like opportunities at all of those layers. But really, as we're framing this right now, like the opportunity for change is at the systems level. I think there has been a lot of precedent of, for a little bit of a dismissive term, like Band-Aid solutions at kind of these lower levels, like, well, let's design like a physician wellness program.
Yes.
And maybe like there's some short-term gains there, but like that's just not recognizing the larger systemic issues, which I think in some cases are like the institutional system, like that university hospital. There's also, of course, like, large hospital systems, the overall US healthcare system. There's many system layers at play there. And then I think that's where it becomes a little bit the like a joke, or people kind of roll their eyes of like, great, I got some like free laundry coupons and a yoga class.
That is exactly what I was thinking of. I think we're thinking there was a well-known emergency department that shall remain nameless for this show that found that their ER physicians were burning out like crazy and just couldn't handle the workload. This is even before the pandemic, but it got worse there. And that's exactly what they did. Well-intentioned, but kind of almost laughable. They gave laundry coupons, and they also gave free meal kits, I think, from Blue Apron. You know, the home cooking sort of prepackaged grocery dinner sort of product where you just have a meal almost ready to go. And, you know, because physicians are like, we don't even have time to get groceries. Well, because we're just back-to-back shifts, and they go over, and that was exactly what I was thinking of. The same example. Yeah. Like kind of almost.
And those things aren't I wouldn't say those aren't bad. Obviously,
exactly.
They're poorly intended, but it's almost like, okay, that's like a little bit to alleviate some like in the moment stress right now, but like, what's the bigger question that they're tackling? So, you know, I know a little bit of that story, obviously, because I was kind of referencing it. I'm sure there's nuances there. So for folks that have worked on it, I don't want to be like overly dismissive there, but yeah, I think there's some of that of like, at that low level, there is a space to play in and a role for designers, but there's really these larger kind of systemic programmatic questions that need to be addressed. And that involves like a lot of different stakeholders, a lot of different opportunities and constraints to make change. And so I think there's definitely roles for design there, but maybe with like a little bit of a different posture and a different type of design toolkit around, you know, collaboration and connection. You know, some of the skills that I learned and use in my work are around like facilitation and bringing people together to wrestle with things. How do you visualize systems so people can understand them and ask the right questions? Which isn't to say that there aren't, you know, very smart, well-intentioned folks who you know don't understand the system, but sometimes you need to like see it in a different way or interact with it in a different way or involve more people in those discussions to see where there's opportunity. But then there's also, again, here with like storytelling, like how do you make the case for change? How do you prototype and explore and you know, iterate your way to that change? But then there's also some really big questions where it's like people who have power are going to need to make some tough decisions about how resources are allocated and used and shared. And this could even be getting up to the level, you know, of, you know, the federal government and like, you know, how our residency programs funded. All of those questions, I think, are germane there. I mean, one, you know, problem space that intersects with this, and I think has some interesting parallels, is around sustainability. So I've done some work over the last few years with folks who are really trying to figure out how to increase sustainable practices within healthcare. And so you're running into like all of these systemic things that we're talking about, and in some pockets, like a real resistance to making changes for the sake of sustainability. And I think there's increasing, you know, examples and frameworks and people who are really pushing this work at different institutions and kind of showing the way. But that too is going to require some tough decisions about resource allocation and the way systems work. And, you know, it's like, back to the discussion around efficiency, like you can only hide your head in the sand for so long before things get exposed. So again, like not to throw Southwest Airlines under the bus, but a little bit of a comparison there of like, at least as I've understood that situation in the winter where they had like massive failures, a lot of that had to do with, again, as I understand it, antiquated systems, things that had not been upgraded, a lack of investment in simple things like a way for flight attendants and pilots to like get a hotel room without having to like be on hold with another human being, like things like that, where it hit them in the face when things failed. And the oversimplified lesson that I was taking from that was like, they should have been investing in that earlier, even though it didn't feel right or it felt economically like whatever. And I think that within healthcare, we saw a little bit of that with COVID.
Yes.
And I think there are some things moving because of that, things that I'm aware of and things that I'm not aware of. But that wasn't like enough. There's more trouble a brewing. So what's going to kind of get people who have power to be willing to take some of those risks, knowing that in the future things are going to happen and we need to be like ready for it. But that's getting us into like all kinds of other big picture conversations.
Yeah, I mean, it almost sort of strikes me that, one of the common arguments I heard, I remember I was part of the crisis planning scientific advisory board for COVID for USC Keck School of Medicine when it first happened. And one of the things that we kept hearing is from especially administrators and people on the non-clinical side, but even some clinicians, like, this is a 1 in 100-year problem. I mean, this last pandemic was basically in the early 1918s, and who would be able to design a system that could have anticipated and respond to something like that? This is such a one-off and an outlier, and there is truth to that. But that was the argument that was used and has continued to be used. Like, well, we can't design a system to respond and to be prepared for things like that when we have more pressing common problems, right? I mean, as they say in healthcare, if you hear hoofbeats, think horses, not zebras. For those that are not clinicians, that's like when you design a differential diagnosis, what are the more common likely explanations, as opposed to things that are more esoteric. So, but I feel like in a field like healthcare writ large, while that is true, we are increasingly being exposed, to use the Southwest sort of analogy, to multiple one-off episodes. I remember a few years back, there were cyber crimes that had hit UCLA Medical Center and a number of notable hospitals, and millions of patient records were suddenly exposed. Well, cybersecurity really had been antiquated at best in healthcare. They never thought about this, even though this was so it seems like almost every year or so there's some new novel thing. So I agree with, like, there has to be a pitch to the I guess the decision makers or the people that control the purse strings. Like, design thinking is important precisely because you cannot anticipate what is going to happen tomorrow, and you need some agility in approach. So I think that what you're arguing, like innovation in systems and design health or design thinking in systems, that I would love that. How do you tell that story to the healthcare community with so many different stakeholders? I mean, you were talking about elevator pitches and imagining if Bill Gates is there or whatnot. I mean, what would be the basic rudiments of that kind of a pitch? Because the counter response is the financial margins in healthcare are so small. This is the most complex industry by supply chain and policy and regulation. So much uncertainty. Obviously there's been a lot of political news about certain elements of healthcare just in the last few weeks and days. There's obviously a lot of attention that, like, this is a very shape-shifting, amorphous, and also very heavy field in terms of what the stakes are, because of obviously everyone's health is sort of tied to that. How do we create the outlines of a different story to people within this world that says, hey, not only will you benefit from design thinking, you need this. This is what you're missing. This is what it could be like if you were to take a step back, take a proverbial semester off, if you will, from your metaphorical school or whatever sort of position you're in. How do we pitch that story? Because I feel like physicians have been trying to, but as you know, there's such a gap between the administrative world with their own culture in healthcare and those in the trenches. And that gap is getting wider, and it's leading to a lot of, there's a massive schism, I think, in healthcare. How do we pitch that story in a way that's going to resonate? Or is it more of like a retail one-on-one thing as opposed to a message that you broadcast?
Yeah. I mean, obviously that's a complicated.
Fix it in 1 minute, please. That would be great.
Exactly. I mean, I can offer a few thoughts. I mean, like, I think there's some value, and I've been doing this throughout the time we're talking in like analogy and looking at other industries. as points of comparison, both for successes and failures. So I think there's some storytelling there around that. Again, I'm not proposing that all healthcare administrators are like naive to that. I mean, lots of them are MBAs and have kind of have been in other industries, but I think there's something there about repackaging some of those lessons or finding the ones that resonate the most with the healthcare space. I think there's also potentially models there to look at in terms of how have quote unquote innovative companies staying innovative. Like, what structures do they have to foster innovation, to foster collaboration, throughout the DNA of the entire organization, or in kind of like pockets where there's a little bit of a playground, or where even people who work in the organization can, take a break and explore, like, and work in these different, sometimes they're like, innovation labs or other things like that. That I think there's been some precedent of that within healthcare, both in, traditional academia, other healthcare systems, within health insurance, and some have been successful and some have failed and some have, gone away. So there's lessons to be learned there, but I think that there needs to be a little bit more of embedding that in the DNA of the healthcare system. And I think that it even comes back to some of our conversations around medical education. Like, we need more folks in the next generation to have some of these skills, to ask these different questions, to want to work in that way, and not to like leave behind everyone else who's already made it through training. Like, what are opportunities? Continuing medical education is supposed to be part and parcel to being a physician or a surgeon. Like, you haven't stopped learning. Like, I feel like there's this historical recognition of like, you need to continue to adapt your skill set. So I think there's also an avenue there for like, what might that look like to have CME in this realm, and probably to the disappointment of some folks, it's not going to be a webinar you can just watch. More interactive than that. So yeah, I mean, I think there's a whole suite of things that are needed. Those are just a few examples to kind of start to shift that story. But there's been people that have been trying this as well. So like, there's injured folks, physician innovators and creators who have tried these things, and I think also have lessons that they've learned from that. But I think we need to lean more on that expertise and that experience for what comes next. But yeah, there's a lot of work to be done for sure. Which again, part of this comes back to, why did I kind of shift my career path? I think I started to sense this as well, of like, if there's part of me that's, interested in healthcare and science and kind of the good that it does, there's all these different ways in which value can be created and impact can be made. And it might not look like what I originally thought, when I was in undergrad cramming for the MCAT.
Right.
And so I also just think that there's something about expanding the way that physicians see their role in all of these problems and bringing those voices in. And I think we've also been a little narrow here with just physicians and surgeons. You just mentioned like nurses. There's so many healthcare professionals who have perspectives and experiences that are valuable, and I think need to be brought into more of these conversations, disrupting the hierarchy a little bit. There's still going to be hierarchy, of course, like that's how things are going to function, but there might be opportunity for more folks to be part of important conversations. Even in the work I've done, there's just so many examples of like, oh my gosh, we would not have known that unless we talked to the person who was doing this thing. We made an assumption. And I think there's just lots of baked assumptions in healthcare that could be questioned. They might still be true, but what would it look like to, wrestle with them a little bit?
I love that. What would it look like? That's just a fun question to ask. That's a brilliant sort of starting point, I think, for anyone that is in healthcare that's struggling with these sort of issues. In the last sort of kind of segment of this talk, I'd like to maybe, pick your brain about maybe one or two examples of sort of design thinking in healthcare that you feel come to mind that really epitomize how this movement and this this school of work, this school of thinking has been really successful. What is maybe an example of like, this kind of paradigmatic approach really solving a particular problem in a creative way that you think epitomizes what design thinking is really all about?
Yeah. Well, the first example that comes to mind is a project that I worked on. So that one I know most.
Let's do it. Yeah, of course.
And I'll caveat by saying this is like a product design physical kind of thing,
Yeah.
which is often like a great way to learn about this, and it's very like tangible. But I just want to like preface it like in some ways it's very limiting, because I think there's, again, like lots of opportunity, maybe even more, and great examples in like experience design, service design, like all of those things related to healthcare. But this is about a product. So when I was a medical student and a student at the D.school, I was part of this class called Design for Service Innovation.
Okay.
And so we had folks from medicine and engineering and business and all of these degree programs. And the framing of the course was we were partnering with different pediatric specialists at the Children's Hospital and thinking specifically of young adults who had chronic illnesses and what was it like to transition from, being a kid to being an adult.
Right.
And kind of all of the implications of the products and the services not really meeting that moment or not really serving young adults in that context. So, going off to college, getting first jobs, moving away from home, even just like managing your healthcare on your own. In my particular team, our focus area to start out with was urinary incontinence. So, in the different manifestations and causalities, young adults who are using products, routines, all of these things to manage their urinary health, and just really recognizing that, like, man, there's a lot of things that have not been done to improve this in a long time. And so in that work, we started by understanding the problem space. So we were, talking to the, chief of pediatric urology. We were talking to the nursing staff. We were talking to parents of kids. We were talking to kids themselves or young adults who kind of speak to that kind of transition, and just really learning about the nuances and the pain points and the things that were working well and the stories and the emotion, like all of that context at a deep level. And where we ended up kind of framing and focusing was specifically on intermittent urinary catheters. So something that, was invented and really hasn't changed much for most people. So even like the simple visual of like the same box of catheters that a teenager would have in their bathroom is what you would see, at, a retirement community in, like an aging grandmother who's enjoying like her life. It's like, those aren't the same people with the same needs. So like, what's a catheter for someone who's clubbing and a catheter for someone who's hiking? Like, what might that look like? And, we were hearing stories about how, like essentially hacks that these kids were using to store their catheters or to use them, or one thing that we weren't even really thinking about in the beginning was disposing of them. Like, one story of someone who went to, a girlfriend's house for the first time, used the restroom, and, it was the nice bathroom with like the hand soap that's no one's ever used, and like the Kleenex and the trash can that's totally empty. And he just didn't feel comfortable leaving his catheter there. So he like put it in his pocket and kind of carried it with him the rest of the day. And so we were just seeing like there's lots of opportunity to rethink how a catheter, an intermittent catheter, could be integrated into someone's life. Then we went about brainstorming and exploring different, ideas and form factors. And essentially what we were inspired by was, could we make an intermittent catheter more like a condom, more like something that's like a personal hygiene device, or more like, a pair of contacts or like a tampon, like something that people have with them. And so we ended up essentially like coiling the catheter and putting it in these two rotating discs. So something that could be packaged about this big. So, you could like have it in your pocket. And we developed that product launched it. A couple of my teammates basically founded a company around that and brought that product into production. So it's called Compact Cath. And essentially it's just a different way of packaging and dispensing and then kind of recoiling and disposing of that catheter. Again, thinking about young adults transitioning into adulthood, gaining more independence. And I think there's a good lesson there that we try to teach our students with design, that while you may be focusing on a narrow use case or a particular person, what you're hoping to do is uncover, a need and an opportunity that resonates with a larger audience. And so very quickly we realized, like, this is not just a catheter for young adults. This is a catheter for anyone who just wants a different way to have their catheter, dispose of it. They have an active lifestyle. We had one person who was like, oh yeah, my dad's 80. He like hasn't stepped down from the board. Sometimes he doesn't catheterize himself because he doesn't want to like leave the meetings. And like, this would be great because he could just have some in his like, sports coat or something like that. So yeah, that's kind of one story, like touching a little bit on like some of the elements of a design process. A lot more nuance there, of course. But for us, it was really exciting to, connect with people, understand their needs, and then develop something that, people can buy now. So.
Yeah, I love that. We're going to actually link that in the show notes, that company, Compact Cath. It actually reminds me of a lot of the discussions I have with my younger patients who have ostomies. I mean, I'm a gastroenterologist, and so, or peg tubes, actually. The social implications of having a bag or having to have a peg tube, a feeding tube, for those that don't know, which is typically into the stomach, that allows someone to get liquid nutrition and medicines, as opposed to having to swallow it by mouth. That's usually top of mind. They're saying very similar things to this story, like, hey, I'm active, or I'm going to be on a date, or I'm going out, or I'm traveling. It impacts how my clothes fit on my body. I feel less confident. I feel embarrassed. What happens if I'm at a restaurant? How do I handle all the paraphernalia of this sort of issue? And there are some low profile devices that aren't as obtrusive, but by and large, this area of medical device making hasn't really advanced as far as it should to meet the needs of patients, typically those that skew younger, but even older individuals. Very similar mindset. So I love this story. What was it about this particular example that ended up not only succeeding on a design level, but succeeded on the level of convincing industry that this is a market worth exploring?
Yeah, I mean, I think some of that really connects to, we've been talking about storytelling. So like the way when we were, developing the product and kind of pitching it to people for funding, or, space in an incubator or something like that. And I think it came from, a genuine approach where the foundation was talking to people who would be using these products and understanding their situations and not leaving it purely at functional. Of course, a lot of this is like understanding function and creating a product that functions in a way, but also understanding like the emotional needs behind that and like the nuances of those stories, and like understanding that, I think, helped us to make a more compelling case for this as something that was worthy of time and investment. And I think there was also just this element of, healthcare and medicine, of course, is amazingly innovative. Like, think of all the drugs and devices and surgical approaches, and like, there's of course so much creativity and innovation there. But I think sometimes, not all the time, of course, it's kind of limited to like what happens in the hospital or what happens in a life situation, and then kind of the like longer term outside of the hospital gets a little bit less attention, or there's just not as clear an avenue. It's like, physicians can do basic science research and publish in scientific journals, but like this other stuff doesn't quite fit as well. And so I think there's lots of questions around that. And again, other folks within the healthcare system who that is their bread and butter, who like They
Yes.
are thinking about what is it like outside of the hospital? What is it like to train a patient to use a catheter, to
Yeah.
integrate that into different activities? And so I think there was also something there in us talking about like, oh, we learned this from the, you know, the pediatric urologist, and we learned
Yes.
this from the nurse, and we learned this from the parent, and this from the patient, and we prototyped at this, you know, camp in the Sierras, and we got feedback from these you know, kids. So it all came together to kind of make sense. And if anything, I think there was a sense of like, why hasn't something like this been done before? Of course, not everything in healthcare is like that. I think there's a lot of things that are more complicated and nuanced. But there's still the same opportunity to address, you know, functional needs and emotional needs and like meaning behind that. But it's got to be more than just making it up, you know. I think that there's got to be a real investment in connecting with the people that you are hoping to serve, and bringing them into that process, you know, throughout. Which is not to say individuals don't come up with great ideas, but I think rarely are those ideas like perfect the first time, and
Yeah.
rarely can actually do it all themselves. They really have to like refine and iterate and acknowledge the, you know, what has gone into that process.
Yeah, I mean, I love this example. So many things come out to me that I want to follow up on, and one is this idea of deep human empathy and this sort of 360 stakeholder approach that you guys took to this problem. Which, in like drug development, for example, yes, there's deep empathy for the patients that are suffering for a condition, but for a lot of reasons, both obvious and non-obvious, you know, does it make a lot of traditional sense to have a patient come in at, you know, preclinical, pre-drug design prototyping stage where you're dealing with protein folding models and, you know, stuff like that.
Yeah.
But even then, the real deep involvement of patients is usually at the clinical trial level. Like, hey, we have this drug, we need to enroll you, sign all these forms, you get a free MRI and an Amazon gift card. Come on, let's do this, right? Very kind of one-sided and asymmetrical. So I love that about what you guys did. The other thing that came to mind is path dependence. You asked, like, you know, why hasn't this been done before when this solution was created? Because it's so elegant, it makes sense, it works, it meets the needs of a community of people that were maybe a little bit underappreciated. And I think my very naive answer to that is path dependence. I think physicians or healthcare in general have so much going on, their bandwidth is so maxed out that there's almost not a questioning for whatever reason of like, could this be done differently? You're not allowed to entertain that. So path dependence, like this is the series of ways that this has already been done. And we're just going to kind of stick with that through inertia. And it's going to be almost like limiting our frame of reference and how we even think. It's like kind of creative blinders that are on. Innovating in legacy institutions that are slow to move, like healthcare, unlike in the kind of VC-backed startup world, or in a company that has a physical product that they're launching, compact cath or Apple's new purported VR headset or whatever, where like you have to have a very deep and clear sense of what your end user is thinking and wanting. And so I feel like, how do you guys work around that? Was that an obstacle in this issue? Did the chief of pediatric urology say, you know what, this is how we've always been doing it. We have admittedly inefficient and antiquated systems, but we know our exact suppliers that give us the exact products that we've been using. Our nurses are trained in how to set that up, and they have their one sheet checklist that they go over with patients in the clinic before they're discharged. And, you know, we still use Windows 95 or MS-DOS to put the order into the Chinese manufacturer, and they know every 3 months we need an order for 20 of this and 50 like. Why are you telling me to just blow all that up because you got this very, I mean, was that an issue that you guys came up against, or was it, my God, we've been searching for a solution to this problem. All of our patients are like, we need better. Our nurses are like, this doesn't make any sense. We didn't have the opportunity to create this. Thank you for bringing this to attention. Was it both? What was the response to that?
Well, I think that the answer kind of speaks to some of the things we've been talking about in terms of like opportunities for physicians to play or explore. So, you know, we were really lucky because this surgeon, I think he had done like a 1-year MBA program at the Stanford Business School.
Okay.
I think maybe in that he had had some exposure to design and design thinking. So he was excited to pursue that and had a little, was entrepreneurially oriented. So I don't know all the details of how things were scoped, because at this point I was a student in the class. Although subsequently, when I was designing another class, I was looking at like the IRB approval document they used for this class, because we were dealing with pediatric populations. But I think there, even if you just limit that, it's like someone being able to, pursue this other degree and explore helped them to be excited to collaborate in this class and to give permission and access and, allow that to happen. And that was kind of like a little bit of an unlock. So I think sometimes here it's also acknowledging like not everyone needs to totally change their career path and become this other type of person and designer. Sometimes it's about like loosening some of the tension, creating some space to explore, having someone again empower who can say like, "Ooh, I think this would be an interesting project to work on." And he continued to participate in the class and advise us throughout and afterwards. And so I think we need more of that. We need more of those nodes within the healthcare system where that can happen, and where people understand like the language of design and entrepreneurship and collaboration, and can kind of bless it in a way, and like let some of that play happen. So I think that was like a little bit of important context that helped us there. And I think he also just saw in framing the class, like, yeah, there's a lot of opportunities to improve the experience of a kid becoming an adult and kind of managing this chronic illness. So I think it was also just came from years of experience, realizing like things need to change, things need to be fixed. Something else that you mentioned, I think that there are times for many physicians, maybe all in training, where they are questioning some things or seeing these inefficiencies or these things that don't make sense, but there's not always, and in some contexts, there isn't any place to like put that. If anything, it's like, stop complaining, learn the system, on to the next rotation.
Yeah.
But I think there's also people who like notice those things, and just the nature, even if they do feel like they can express that, the nature of training is you are on another rotation. It's out of sight, out of mind.
Yeah.
And then you become the physician or surgeon that you are. And so sometimes I think that gets like left on the playing field. So I still think there's this real opportunity for when physicians are being trained to have outlets for identifying, problems or opportunities. Hopefully then also like outlets to pursue that, to work on that a little bit. And I'm not saying that doesn't happen anywhere, but sometimes it's kind of limited to like a 1-month QI project, which you can do some interesting things with that. And I think there's a lot of connection between design thinking and quality improvement. And that's often how you can reframe design thinking to fit with the mindset of medicine.
Yeah.
But sometimes you need a little bit more time than that, or it needs to be longitudinal, or you need some skill building in addition to that. So I'm just, there's things that can be leveraged. We're not starting at zero.
Yeah.
But that's one thing that really stands out to me in terms of training is trainees are at a place where they are asking different questions than the incumbents. So what can we do with that?
Yes, this I love that. I mean, I feel like I have definitely seen that in my, clinical experience, both when I was a trainee, when I sort of mentor them, like they have less path dependence of their own thinking. They haven't exposed as much, so they're allowed to entertain in a way that is refreshing questions that sometimes it's harder, as you say, for incumbents to sort of point out. It reminds me actually of the section of Walter Isaacson's profile of Steve Jobs. I don't know if you read that, where, for those that don't know, obviously founder of Apple and perhaps the most popular exponent of design, product design in this case, and then software design for a mass market to great success. He ended up having pancreatic cancer that obviously spread to his liver. That's what ended up killing. He got GI care at USC or at Stanford, but when he was transferred to a different facility to get transplantation evaluation, he was critically ill. I mean, in the book, Isaacson profiles how his design mentality couldn't stop. He was trying to, because as I've noticed, everything is kind of poorly designed from a human functionality standpoint in healthcare, from IV poles to the ventilators to the nasal cannula, which is a tube that is put around someone's face into their nose to give them extra oxygen. His mind was just going off to the races, even as he was frankly, unfortunately, dying. And he was sketching out all kinds of ideas, like, what if we created a medical bed that had this sort of thing? And what about this? And like, this almost reminds me of like the plethora of opportunities that exist in medicine for all the levels of design that you pointed out: experiential and service design, product design, system design, designs in our thinking. I wish that there were like 1,000 points of light where people could sort of innovate and create these opportunities. I mean, in our prior call, we were talking about, for example, you had sent me the link to the speculum that was created to kind of provide a better experience for women or people with, female reproductive tracts, because that is obviously a very, I've done some of these exams and, for what people have told me, and, such a terrifying and sometimes uncomfortable experience, to novel scrubs, to different medical equipment. I really hearken everyone to take a very deep approach to what David is saying, because this is what we need. This is exactly what's going to revitalize the field. This kind of fresh air and new thinking that I think physicians, healthcare leaders, nurses, and frankly all of us as patients, because we're all patients in some regard, are really looking for. As a last kind of question, because I know we've taken so much of your time, you've been so generous. Where do you see the future of design thinking as it applies, maybe just in the field in general, or perhaps in healthcare? Because I think that what I point out, healthcare has the most complex supply service chain of any industry. We have like probably 20,000 different drugs, at least 10,000 medical and surgical unique procedures. This is probably only increasing. Every week there's a TV ad, ask your doctor about blah, blah, blah. There's now design for virtual health services, digital health. There's different ways of delivering care. Things have really exponentially got more complicated coming out of the pandemic. Where does design thinking need to go, perhaps, to kind of meet the moment and the coming sort of challenges of modern healthcare and a modern society that is both more invested in health than ever before, but is also increasingly sicker? Or maybe where does design thinking writ large? I know this is a large question, but I like sometimes asking some of these high level questions that kind of get sometimes interesting answers. Like, is it doubling down on everything that has worked for all these years and decades, like more work on radical collaboration, full investment into the human experience of this particular product or whatnot? Do there needs to be some radical collaboration with other disciplines? Where does the field go from here?
Yeah. Okay. Three things come to mind. And these are all three things that the d.school at Stanford has been investing time in. And so for me, that's like a pretty good proxy signal of like, where does it feel like there's it's worth investing energy?
Yeah.
The first kind of category, I think, is around emerging technology. So what does it look like to be designing in the space of emerging technologies like, AI and machine learning and, cryptocurrency and virtual, all of these other things that are quote unquote, highly technical, and maybe the posture or the inertia is like, oh, well, that's for like the tech people to be working on. But there's been a real emphasis at the d.school on this is where design thinking has an opportunity, because if design thinking is about radical collaboration, bringing in diverse perspectives, bringing in different stakeholders, really trying to understand and reframe problems, I think the approach there is like all types of designers should be playing in these emerging technologies, and all types of non-designers should be part of those conversations early. And so design thinking has a role to kind of foster that collaboration. And I've gotten to dabble a little bit in that. We talked earlier about a class I taught during the pandemic that was about the emerging role of virtual reality in healthcare, which even in the last couple of years, that's blown up even more. But that was just a real fun opportunity to like play with an emerging technology, have a mix of students who were interested in healthcare and some who were not, and really just getting exposed to emerging technology and asking questions and coming up with designs and just being able to play in that space and realize like where are their constraints and where are their unknowns and where are their ethical dilemmas. So I think there's something there around emerging technology. I think there's a lot of work that's been happening by a lot of folks already around power in design. So you maybe hear terms like equity-centered design or community-centered design, approaches in co-design that are really seeking to understand, or it's maybe already understood, but to acknowledge and spread the notion of like the role that power plays in design and who should be designing and how should that be happening and what are the tools and approaches that are ethical and kind of acknowledge the complexity of the human experience and really center the folks who those designs should be created by and for and with. And so there's all kinds of work being done there. And then I think a third area, which we've touched on a little bit, related to the different layers of design and systems design. Systems design has been around and there's tools and frameworks, but I think that's continuing to evolve, and the connections that designers are making in systems design, the stakeholders there, how are you marrying techniques of, human-centered one-on-one design with systems design and having that kind of feed together? What does it mean to design for the long term as opposed to just, 1 to 5 years? How are we designing for 10, 20, 30 years? What does that mean? So those are kind of three areas that first come to mind when you ask that question.
I love that. I think those are fantastic sort of talking points for the future. I think that, especially with the first one, emerging technologies with sort of remote patient monitoring, virtual reality, which you pointed out, AI is probably the biggest buzzword in healthcare. I think that, ultimately those are areas that don't have as much incumbent pressure and presence, and hopefully it has a little bit more of an open landscape for people to kind of work with. So thank you so much for this conversation. I've learned so much. I am so jazzed. I feel like I wish I was at Stanford back in the day, earlier in my career. I'm kind of jealous that you've had that opportunity. If people want to learn more about working with you, your work, or dipping their toe into design thinking, how can they connect? How can they learn more? How can they reach out?
Yeah, I do have Twitter. I haven't been very active in terms of posting things in a few years, but I'm just at David Janka on Twitter. And so there, even some like examples and things are there in like previous posts, or folks could also DM me there, and we can get in touch from that. I'm on LinkedIn, so if you find David Janka, I don't think there's many. There might be a couple other ones, but it should be pretty clear that mine has like the design and healthcare in there. People can reach out there and message me. I think those are like two good initial channels. And then other than that, I do teach and work at the D.school, but I also, consult and do talks and things like that. So, often I'm kind of talking with people and kind of scoping and trying to figure out what they're interested in and giving them, leads or resources or things like that.
Wonderful. I love it. I cannot thank people enough. I think the biggest takeaway that I've learned that I think our audience is going to get is there's two. One, the scope of possibility of what is doable in terms of innovation. And I think to a certain degree, we have all been children of a lesser God, if you will, in healthcare, because there's been such resource constraint, such focus on efficiency in the short term at the expense of long-term investment, path dependence, sort of belabored inertia. That sometimes I think we forget that there is actually a whole wonderful, rich opportunity to be creative, yes, even in healthcare. And that has been the biggest takeaway with the numerous examples you've pointed out. Number two is that I think a radically different approach to human empathy and to stakeholder empathy, which it seems I'm learning from you is really the key to great design, no matter if it's service or product or what have you. And I think that we have a fairly profound, but also sometimes narrow scope of what that means on the medical and healthcare side. I mean, even a story with the catheter, like, oh yeah, there's some unique transitions with kids that are growing into adulthood. They're going to have slightly different challenges, or maybe even deeply different needs than catheters are typically made for people much older, different life phases. That story itself, like radical human empathy and collaboration with them, being co-creators. I love that co-creative process. So that's the second biggest takeaway I get. It reminds me of a children's hospital here in Southern California that did something as simple as putting stickers of like Superman and Batman and Spider-Man on chemo IV bags. Mm-hmm. Just because that little kids could feel like they're a superhero when they're holding their IV pulls and they're getting their infusions. And it allowed them to take the mental leap from, I'm just a patient, I'm just a kid, to like, no, I could feel strong. And, simple things like that, or complicated ones like the ones that you just described. Radical human empathy. I love these messages. I think this is the kind of movement that we really need on a foundational level. I don't think this is tangential to the challenges that we face in our industry. I think they're central. So thank you for sharing that message. Thank you for taking time. We're going to link all of your profile and content to our show notes. So highly encourage everyone to reach out to Dr. Janka, Doctor as Designer. Thank you so much. This has been another amazing episode of The Alchemy of Politics.